Drbeen.com. Today we are going to look at two more studies for COVID-19. One of the study, they both are very fascinating. One of the studies is the low-dose radiation therapy for management of the COVID-19. So it's a small study, but beautiful results, and it is interesting to look at. I'm going to show you some of the trials that have started based on this kind of a study, plus another article where the authors have discussed the pros and cons of the radiation therapy. So let's start our discussion. The second part of the discussion today will be about the immunity. So there is a study from China that shows that the immunity in patients who had become infected starts reducing within 2 months. And that is a concerning, if that is the case, then that is a concerning situation, because if somebody gets the infection today, recovers, we are hoping, based on the MERS-CoV, that is the Middle East Respiratory Syndrome coronavirus, and the SARS-CoV-1 in 2002, based on those studies, we knew that the immunity would stay for about 1 year to 3 years. And here we are looking at a study that says that the immunity to SARS-CoV-2 only, I shouldn't say only stays for 2 months, but it starts declining at 2 months. So we would look at that together and see if that is really the case that should happen or not, and how concerning that should be. So let's start looking at both of those studies. Welcome everyone. I'm going to start sharing my screen and we'll go from there. So this is the first study. In this study, what we are doing is that the authors have given low-dose radiation therapy to the patients. So it's a small study, about 5 patients only. So they've given low-dose radiation therapy to 5 patients, and they have observed the clinical outcomes. So let's see what they have done here. So here is the setup. So they have radiation therapy. They did the beam configuration was anterior posterior beam configuration, that the radiation was done on both lungs bilaterally, or both lungs, and then it was given for 10 to 15 minutes. The amount of radiation was given 1.5 grays, which is equal to 1 joule per kilogram, or in the older terms, 100 rads. So that was a study. Let's look at the study itself. Actually, let's look at what it does. The idea of this study is this, that when the radiation therapy is given to, let's say, lungs, what would happen is these are macrophages, and we know they look a little shocked. Let's make them happy people. So these are macrophages. Excuse me. So we know that when macrophages encounter a pathogen and they take it up, in response, when they become a little more active, or when they present the antigen, they also start releasing interleukin 6. Remember, they release interleukin 1, 6, 8, and many other, tumor necrosis factor, and so on. Interleukin 6 is important because this would then, in turn, one, cause fever. Secondly, the interleukin 6 works on the liver to help produce the acute phase proteins, and then interleukin 6 works on the other immune cells and activates them, activates the other cells. So it is a pro-inflammatory interleukin. So that means if we suppress this, that would help suppress the cytokine storm. So in the older days, radiation therapy has actually been used. When this was the era before 1940, when we had less antibiotics, in those days, radiation therapy used to be used for the cytokine storms. So that is the same theory which has been invoked again at this time and used in the COVID-19 patients. So let's look at the study itself. So here is the study. So let me just go to the top of the study. So the study is by Muhammad Khan, MD, PhD, FACRO, Associate Professor, Director, Radiation Immuno-Oncology, and this is from the Emory University Hospital. So let's see what they did. What they did was, we performed a single institution phase 1-2 trial evaluating the safety and efficacy of single fraction low dose whole lung radiation for COVID-19 pneumonia. Eligible patients were hospitalized, had radiographic pneumonic infiltrates. So they were in the hospital, the patients. They did have abnormal lung reading, required supplemental oxygen, and were clinically deteriorating. So that was their criteria, that the patient has to be deteriorating. So what they did was, out of all the patients, so again, small study, they had 9 patients, excuse me, out of those 9, they had actually selected 5 patients based on their criteria. Now, once they gave them the radiation, what happened was, so within 24 hours of radiation, 3 patients weaned from supplemental oxygen to ambient air. That is excellent. 4 exhibited radiographic improvement, and median Glasgow Coma score improved from 10 to 14. So the Glasgow Coma score is to see the level of unconsciousness of a person or level of coma of a person. So improving score towards 14 is actually very, very good. A 4th patient weaned from oxygen at hour 96. Mean time to clinical recovery was 35 hours. There were no acute skin, pulmonary, GI, GU toxicities. So that is the most important thing to see here, because radiation can cause toxicity, and this is low dose radiation, and the toxicity was not observed in the acute phase. Maybe there is a long-term issue, but in the acute time, there was no toxicity. So if you look at their study now, look at this. 5 residents of nursing or group homes with COVID-19 outbreaks. So keep this in mind. They are residents of nursing homes. So they are folks with higher age, advanced age, and possibly some comorbidities as well. So for them to have response to radiation therapy while they are deteriorating and while they are on the oxygen, while they have lung damage, is a very, very important thing to keep in mind. So each had pneumonia visible on chest X-ray, required supplemental oxygen, and had clinical declined. A single treatment of low-dose 1.5 gray radiation to both lungs were delivered over 10 to 15 minutes. Within 24 hours, 4 patients rapidly improved their breathing, recovering at an average of 1.5 days, and had either been discharged, 3, or were preparing for discharge by 14th day. This is excellent. And I want to show you one last point about this study. I want to show you because they were just 5 patients, they actually have the data here. So let me see. This is the data. So patient 1, patient 2, patient 3, and patient 4 and 5. Look at their ages. 90 years, patient 1. Patient 2, 70 years. Patient 3, 90 years. Patient 4, 90 years. Patient 5, 60 years. So advanced age, where having a good outcome is actually slightly difficult. Gender, female, 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 and 1 male. And then look at this, their symptoms: fever, dyspnea, and hypoxia. Hypoxia up to 80 saturation. That is really tough. Fever, dyspnea, hypoxia, and diarrhea and confusion. Fever, dyspnea, hypoxia, diarrhea, body aches, and all of them, except the very first patient, had the oxygen saturation down to 80. And then if you see here, this is what is interesting for me, that the last row here, deterioration. Mental status was changing in these 3 patients. Rising oxygen need was here in this patient. Rising oxygen need was here in this patient as well. So this cat that is speaking now, she is Kyrie. She's not Luffy. Luffy has a more more aggressive cat. This is Kyrie. I don't know if she's a hungry kitty, but she is someone who is today decided to talk. Okay, so this is the first study. Now let's look at the second study. Let me just comment on the first study. The comment here for the first study is that it is interesting that the low dose radiation can be useful. I want to show you a couple of more things about the low dose radiation before we continue to the next study. So number one, here if you see, this is the actual study, low dose whole lung radiation. Then this is a clinical trial. And if you see here, this is low dose radiation therapy for COVID-19 pneumonia. This is going on in All India Institute of Medical Sciences, New Delhi. And they are starting with 10 patients, or they are requiring 10 patients starting from June 13, which has started, and ending in August 2020. Here is one more trial of low-dose radiotherapy in COVID-19 pneumonia. This is in, I believe, Iran, and this is Shahid Bahishti University of Medical Sciences. They are looking for 5 participants and May 4 till December 2020. So these are the studies. And I also want to show you this. This is an article that was published in June 2020, that is this month. Here they have said, low-dose radiation therapy for COVID-19 pneumonia, a double-edged sword. So the basic message here again is the same. Their message is that because low-dose radiation causes immunosuppression, that can actually allow immunosuppression in the whole body. It's not just the lungs that would be, when treated, would become low on immune response, but the whole body can become low on immune response, and they think it may not be the right thing to do. So I partially agree with their message. The reason for that is, the reason for me to be partially agreeing with this is that we have all seen in our previous discussions that when a patient is in cytokine storm, that storm is actually spreading throughout the body. And the cytokines and the chemokines and the chemical substances of inflammation, they are going to cause damage to the blood vessels as well, which then causes hypercoagulable state, which then causes clotting and further damage to the tissues, leading also towards the septic shock. So if there is a radiation therapy, which can then actually reduce the inflammatory response throughout the body, that would actually be fine. So again, we have to look at that letter as well. I think the, excuse me, doctors have to figure it out, that what is the right thing to do for the patients. The good things that I see about this study are that the patients were in advanced age, and secondly, they were requiring oxygen, and they turned back from there. The limit in this study, I believe, is that the number of patients is too small to be able to say that this can reliably be done. So larger studies are needed. So this is the first study. Now let's go to the second study. So the second study is and this is fascinating, and when I looked at it, I was a little scared as well. Although I think there are reasons that we don't have to, but hear me out here. This study came out of China. Here is the study. So the study says clinical and immunological assessment of asymptomatic SARS-CoV-2 infection. So basically what they're doing is they're looking at the people who are asymptomatic but have SARS-CoV-2. And they were trying to figure out what are the clinical characteristics of the people who are asymptomatic. In that, they were also trying to measure that will they shed and how long will they shed. So while they were doing that, they were taking care of their serology as well, or antibodies as well, and they found out that their serology was actually very interesting to look at. So let me just show you here. We studied 37 asymptomatic individuals in Wanzhou district who were diagnosed with RT-PCR confirmed SARS-CoV-2 infection, but without any relevant clinical symptoms in the preceding 14-day and during hospitalization. So these are the folks who were RT-PCR positive, but before hospitalization, 14 days before hospitalization, and during the hospitalization, they did not develop any symptoms. So they stayed asymptomatic, but they had RT-PCR positive. And they looked at these patients to see what happened. So let's now look at the study itself. So total patients in that hospital were 178. Out of that 178, 37 were asymptomatic, which makes up about 20.8%. But again, these are 20.8% out of the confirmed cases. In the general population, there may actually be a different percentage of people who are asymptomatic. Now, the data that they saw was interesting, but before we go to data, let me show you something here that we've discussed before as well. And that is, look, let's say this is the time scale here. And let's say a person becomes exposed to the virus here at day 0. The person develops symptoms usually from 2 days to 14 days. Median is 5.1 days, correct? But let's say here, the person was supposed to develop symptoms and they did not develop symptoms or develop. They stayed asymptomatic or they were symptomatic. But what happens is in about 10 to 14 days, they start developing IgM, correct? And then IgM has to go down soon. IgM is a acute phase immunoglobulin. It is produced in the early part and then it goes down. And then the other is usually IgG, which is another immunoglobulin that is produced a few days later and then stays up for a longer period of time. This is the usual response in infections. However, we know that in SARS-CoV-2, the IgG actually starts coming in with IgM, and then it is supposed to stay there for a longer period of time, and we do not know how long. And that is the study is about. So that is one, that how long does it stay? Secondly, we know that the antibodies are of two types. One type are, so let's say this is coronavirus, and these are spike proteins. We know that antibodies can be the one that bind to the spike protein. These will be called neutralizing antibodies because once they bind to the spike protein, spike cannot bind with our ACE2 and the coronavirus cannot infect our cells. On the other hand, there can be simply binding antibodies which can just bind anywhere on the virus and they may not have any bad effect on the virus. So they looked at both the binding antibodies and neutralizing antibodies. And now let's look at the data. The data is this. This is the asymptomatic people. The median age in the asymptomatic people were 41. Chest CT, there were 56.8% of the people had asymptomatic patients had abnormal CT. So either ground glass opacities or other infiltrates. 43.2% of the asymptomatic patients in this study, 37 patients, were normal. Median virus shedding, and here the definition of shedding is not necessarily infectivity. Infectivity will be from the patient to another person. Here the shedding simply means that the first day that the RT-PCR was positive to the last day RT-PCR is positive. That is the duration they called shedding. So this is why there is this, that it does not necessarily mean infectivity. It simply means that virus was present in their oropharyngeal area. So the asymptomatic patients had the virus in their nose and pharynx for 19 days, compared to symptomatic patients who had it for 14 days. That means asymptomatic patients were able to clear the virus at a lower with a lower response. So they had the virus in them for a longer period of time. Their immune response was weaker. Then if you look at the IgGs, so these are the antibodies, this is what I wanted to do. There are two phases, acute phase and convalescent phase. Acute phase means when the RT-PCR was positive, when we can say that they were actually infected. And the convalescent phase is when the RT-PCR became negative, we feel that the virus is gone and the antibodies need to be there, so the patient is recovered. So let's look at the acute phase IgGs. In 81.1% of the patients, they had the IgGs developed, which is good. 83.8% of the symptomatic patients had the IgGs developed, which is fine as well. And here IgM, the short duration antibody, 62.2% patients had IgM. That is curious. that a smaller number of patients developed the acute response, while 78.4% of the patients who were symptomatic had the response. And this measurement was done 3 to 4 weeks after the exposure. And we know that about 10 to 14 days are taken by our immune system to activate the adaptive system that makes the antibodies. So to be on the safer side, they had measured it 3 to 4 weeks after. Now let's look at this. This is interesting. This is the antibodies in convalescent stage. That means the patient has recovered, either asymptomatic or symptomatic. 71.1% decrease in IgG production. So patient who was asymptomatic was RT-PCR positive after about 2 months. What they observed was the researchers that 71% reduction in IgG. IgG should have been chronically present for maybe a year, for 2 years, for 3 years, if we consider their cousins of the coronaviruses. And then what they saw was that within 2 months, the immunoglobulin had dropped by 71%. Not to 71%, I believe, by 71%. And then in the symptomatic patients, the IgG had dropped by 76.2%. So that's a very large drop in immunity. And this is also very important. And actually, this is a ray of light in this one. The neutralizing antibodies, the antibodies that actually matter, the antibodies that would actually bind to the spike protein and cause the spike protein to become ineffective. These antibodies, the neutralizing antibodies, were reduced only by 8.3%. So that is a good news. That is a good news. And then in symptomatic patients, 11.7%. So that means they were still continuing to have the capability to protect themselves because neutralizing antibodies were not dropped by a very large percentage. But concerning thing here is, why was it dropping at all? In the MERS-CoV, that is the Middle East Respiratory Syndrome virus, that was 2012 to 2015. In MERS-CoV, the antibody level started dropping after a year. Here they are seeing the antibody level dropping within 2 months. And in SARS-CoV-1, 2002, the antibodies level started dropping after 2 years. And then they diminished to a negligible level within 3 years. And here, once again, antibody levels have started dropping within 2 months. That is a concern. Now, what is not known is that would this just continue to drop slowly and maybe continue to go on for a year or so or not? And the second thing that is not known here, which is, of course, cannot be done, is that if these patients were reinfected, would that have actually, this level of antibodies, would that have been sufficient to protect them? It is possible that, let's say for virus, let's say 4 viruses, let's say for SARS-CoV-2, we need 100 neutralizing antibodies. Now they have 100,000 neutralizing antibodies. Out of those 100,000, 7% are reduced. Then what? We still have a large number of antibodies available. So maybe another 5% reduces a month after. Even then we are fine. We only needed 100. We still are in hundreds and thousands. So this is what is not known, is that if the patient is reinfected, then would the patient actually still have sufficient antibodies or not? If the antibodies levels fall below this state where the patient can be protected, then that will be very concerning, because that would mean that every 3-4 months the virus is going to attack us again. I don't believe in that. I think the immunity would be for long term, but still we do not have enough data. So this is the discussion for today. I hope that this was interesting. I saw one article today. Let me just talk about that as well. We have a few minutes. I saw an article that said that Pakistan reports first case of coronavirus reinfection. I believe that we saw similar articles in March as well that came out of Korea and Japan too. And the reason in those cases was that either the first test done that declared a person negative and be discharged from the hospital, that was wrong, and the patient actually still had the infection, and when they followed up in a few weeks, the patient was still RT-PCR positive. That was one possibility. Second possibility was that the patient was, the test kit used first to declare them negative was correct, and the test kit used next was probably incorrect or even more sensitive. Or there may have been the collection of the swab or the material that wasn't. So there could have been many errors instead of reinfection. Although here in this is not a study, this is a person who reported on his Facebook that he has seen a patient who was COVID-19 positive 2 or 3 months ago, and now they appeared again in the hospital with infection, and they themselves were a doctor, and that person now has more intense symptoms. It may have been that the person was not COVID-19 positive earlier. It may have been that they had common cold, or they had typhoid, or maybe they had COVID-19. There is nothing, no science in here yet, but I just wanted to make sure that we look at this as well. So with this, our discussion for today is done. Tell me, what would you like to discuss tomorrow? I have a number of discussions. What I wanted to do was, I wanted to go back to what's happening in the vaccine world. Where are we? When are the trials starting? And I wanted to look at some of the hydroxychloroquine trials and the results, that recovery trial and the other trials, and some data that is coming out of India. If you would like that, we can talk about that tomorrow, or please provide me a topic that you would do. And hopefully you're all staying safe and happy, taking your supplements. Send me the pictures of your supplements. I'm going to show them here, and we will go from there. Thank you very much. Stay safe and happy. Please like, subscribe, and share, and we'll go from there.